Okay, let's unpack this. When we talk about shock today, we aren't talking about, that momentary sense of surprise or emotional trauma.
No, definitely not.
We are diving into shock as a critical, life-threatening failure of the human machine, really one of the most urgent medical emergencies possible.
It really is. It's the ultimate hemodynamic crisis.
Yeah.
Fundamentally, we define shock as a state of circulatory failure.
Okay.
And that failure severely impairs tissue perfusion.
Perfusion meaning getting blood flow to the tissues.
Exactly. Getting blood and, crucially, oxygen around the body.
Yeah.
When that system collapses, it leads directly right down to the cells to widespread cellular hypoxia.
Hypoxia. So
Yeah.
a profound lack of oxygen at the most basic level.
Precisely.
And the gravity here is immense because the clock is always running, isn't it?
Absolutely ticking.
Our sources underline that while an initial injury, maybe a severe bleed or a massive infection, might be manageable at first, if this state of hypoperfusion continues too long.
Then the body just spirals. It rapidly leads to irreversible tissue damage and ultimately multi-organ failure.
It's that cascade effect.
It's the cascade that makes it so dangerous, yeah. And shock can complicate almost any severe condition.
Like what?
Well, severe hemorrhage from, say, a ruptured aortic aneurysm, massive trauma from an accident, a major myocardial infarction, a heart attack, or maybe the most insidious of all, microbial sepsis.
Right.
So what we need to understand today is the step-by-step mechanism, the pathology. How does a manageable crisis turn into this systemic breakdown?
And that's our mission today. Move past the simple definition, like just low blood pressure, and really understand the complex underlying issues. We're tracking the process from the initial insult right down to the molecular signaling that shuts the body down.
And that understanding is absolutely crucial for you, the learner.
Yeah.
Because, the treatment for one type of shock can actually be harmful for another type.
Can you give an example?
Sure. If you aggressively push intravenous fluids into a patient whose heart pump has failed, that's cardiogenic shock, you'll just flood their lungs. You make things worse.
Okay, so you have to know the source of the failure.
You have to start there. And we also have to acknowledge the high mortality rates, especially with cardiogenic shock and particularly septic shock. They're tough.
Okay, so to structure this huge topic, let's start with what our sources call the 3 pillars of circulatory collapse. Basically, categorizing shock based on where the failure starts in the system.
That's a good way to think about it. You've got the pump the heart, you've got the volume of the blood or fluid, and you've got the pipes, the blood vessels.
Right.
Failure in any one of those leads to shock. Hashtag tag checks daily. Categorizing the failure.
Let's start with the pump itself. Cardiogenic shock.
Okay, so this is a state of low cardiac output, low blood flow out, resulting directly from the myocardial pump failing. The heart muscle just can't push blood effectively.
And the most common causes?
Usually extensive intrinsic damage, typically a massive myocardial infarction, a heart attack, that kills off a significant chunk of the working muscle tissue.
But it's not just muscle damage, right? Obstruction can also cause pump failure, functionally speaking.
Absolutely. The pump failure can also be mechanical or obstructive. Think of things that stop the heart from filling or emptying properly, like cardiac tamponade. That's where fluid builds up rapidly in the sac around the heart, physically squeezing the ventricles so they can't fill up.
Okay.
Or a massive pulmonary embolism, a PE. A big clot gets stuck in the pulmonary artery, blocking blood from leaving the right side of the heart to go to the lungs. Functionally, the right ventricle fails because it's pumping against, a brick wall of resistance, so systemic output drops.
And arrhythmias, too. Irregular heartbeats.
Yes, they can fall here, too. Chaotic electrical activity means no coordinated, effective pumping.
Okay. So if the pump is actually working fine, but there's just not enough fluid for it to pump, that takes us to hypovolemic shock.
Correct. Hypovolemic shock means low cardiac output because the circulating volume is just too low. Not enough blood or plasma volume.
Simple as that.
The mechanism is pretty straightforward, yeah. If you lose, say, 30–40% of your blood volume, the heart doesn't have enough returning to it to eject efficiently. It's pumping air, essentially.
What are the main triggers for losing that much volume?
Well, they fall into 2 main buckets. First, massive hemorrhage, losing whole blood rapidly, either externally, like from major trauma, or internally.
Like a ruptured aneurysm.
Exactly, a ruptured abdominal aortic aneurysm, or maybe massive internal bleeding after a car crash.
And the second bucket.
That's severe fluid loss, meaning plasma loss. This happens with like relentless severe vomiting or diarrhea.
Yeah.
Or maybe most dramatically with extensive thermal burns.
Burns. How do burns cause fluid loss?
With major burns, massive amounts of plasma leak out of the damaged capillary beds under the skin. It just pours out into the tissues and blisters.
Okay. Now we get to the really complex one. Shock associated with systemic inflammation. This includes sepsis and the related SIRS, right?
Yes, this is the molecular labyrinth. It's fundamentally different.
How so?
Unlike the first two, which are basically mechanical or volume problems, here, the issue is an overwhelming systemic activation of inflammatory cascades.
Inflammation. Okay.
This leads to profound peripheral vasodilation. The blood vessels just open up everywhere, combined with widespread vascular injury, making the vessels leaky.
So, wait. If I understand this, in early septic shock, the heart might already be pumping hard, maybe even harder than normal.
Exactly right. Cardiac output might be high or normal initially.
But the blood pressure is still catastrophically low.
Precisely. Because the circulation has become this dysfunctional, leaky sieve.
Ah, okay.
Imagine trying to run a pressurized sprinkler system when all the hoses have sprung holes and the valves are wide open.
Right.
You can pump water like crazy, but you can't maintain pressure or get water where it needs to go effectively. That's septic shock in a nutshell.
And just briefly, we should mention the less common forms, neurogenic and anaphylactic shock. They share that vasodilation mechanism.
Yes, good point. Both neurogenic shock, often from a spinal cord injury cutting off sympathetic nerve signals,
And anaphylactic shock, the severe allergic reaction.
are primary vasodilation problems. They cause this acute, massive relaxation of peripheral vessels.
So the container gets suddenly huge.
Exactly. The circulating volume, which was normal moments before, suddenly can't fill the vastly expanded capacity of the circulatory system. That causes immediate, life-threatening hypotension and hypoperfusion. The pump's fine, the volume's fine initially, but the system's just tag Beta1.
The 3 stages of physiological descent.
Okay, so we've got the source of the failure pump, volume, or pipes inflammation. Now let's track what happens physiologically step by step once that failure begins. We can use the hypovolemic model as a clear map. Yeah, that works well. And this progression really highlights the difference between an injury you can recover from and, well, an inevitable tragedy if it's not corrected. #1. Initial non-progressive stage, compensatory phase.
First up is the initial non-progressive stage, the compensatory phase. The body fights back immediately, right? Tries to fix the problem.
It does. The body is brilliantly designed to buy time. Several high-speed systems kick in almost instantly.
Like what?
First, the baroreceptor reflexes. Pressure sensors in the big arteries detect the pressure drop and fire signals straight to the brainstem.
And the brainstem responds how?
By triggering a massive release of catecholamines, adrenaline, and noradrenaline from the adrenal glands.
Ah, the adrenaline rush. What does that actually do here?
2 critical things.
Yeah.
Speed and squeeze. It causes tachycardia. The heart speeds up to maximize output, and it causes massive systemic peripheral vasoconstriction, squeezing the arterioles, the small arteries.
And that squeezing is the shunting mechanism. That explains the classic cool, pale, clammy skin sign we hear about.
That's the outward sign of it, yes. The body makes a ruthless calculation. Sacrifice blood flow to non-vital areas.
Skin, gut.
Skin, GI tract, even the kidneys initially, to maintain perfusion to the absolutely essential organs. The coronary vessels feeding the heart muscle, and the cerebral vessels feeding the brain.
Okay.
Their flow stays relatively normal during this stage, assuming no prior issues. The body is buying critical time.
And it's trying to hold on to fluid, too.
Precisely. Hormonally, the brain releases antidiuretic hormone, ADH. That tells the kidneys, hold on to water.
Right.
And crucially, the renin-angiotensin-aldosterone system, or AAS, activates. The kidneys sense low flow, release renin, which ultimately generates angiotensin II.
Which is a vasoconstrictor.
A potent vasoconstrictor, yes. And it also triggers aldosterone release, which makes the kidneys retain sodium, and water follows sodium.
Yeah, okay.
So more volume retention, more pressure. These are the body's defenses trying to stabilize things.
Now, this is where we need to hit that contrast again for the learner. Cool, clammy skin isn't universal in shock.
Absolutely vital point. While hypovolemic and cardiogenic shock, patients usually are cool and clammy because of those catecholamines squeezing the peripheral vessels.
Mm-hmm.
Early septic shock is often the opposite.
Why?
Because of the overwhelming flood of inflammatory mediators causing vasodilation. They override the catecholamine signal. So the patient might actually present initially with warm, flushed skin, maybe bounding pulses, even while their blood pressure is dangerously low.
So never rely just on skin temperature.
Never. It's a clue, but not definitive for all shock types, especially early sepsis. Hashtag tag 2, progressive stage.
Okay, so if the underlying problem, the bleed, the heart attack, the infection isn't fixed, the body's compensation starts to fail. We move past buying time and enter the progressive stage. What marks this shift?
This is the real turning point. It's characterized by widespread, sustained tissue hypoxia. The cells are truly starving for oxygen now.
And that forces a change in metabolism.
It does. Remember the mitochondria, the cell's powerhouses. They rely on oxygen for efficient energy production, aerobic respiration.
Right.
When oxygen isn't available, they're forced to switch to the emergency backup, anaerobic glycolysis.
Which is less efficient.
Much less efficient, produces only a tiny fraction of the energy. And its byproduct is nasty in large amounts. Lactic acid.
Lactic acid. That's not just a marker, it's actually harmful here, isn't it?
It is. It's the key measure of the body's oxygen debt. In the clinic, we measure lactate levels. Often anything over 2 mmol is considered elevated. And treatment goals often focus on lactate clearance, maybe aiming for a 20% drop every couple of hours.
Why is clearing it so important?
Because the buildup causes metabolic lactic acidosis. The tissue pH drops dramatically.
And that drop in pH is what really messes things up.
It dismantles the compensation. The acidosis blunts the vasomotor response. Remember how the body was desperately trying to constrict arterioles with catecholamines?
Yeah.
Well, the acidic environment makes the smooth muscle around those arterioles relax. They dilate. It essentially cancels out the effect of the adrenaline. The compensatory fight is lost.
Wow. So that creates a terrible vicious cycle. Lack of oxygen causes acidosis.
And the acidosis causes vasodilation.
Which leads to blood pooling in the tiny vessels, worsening perfusion.
And which further starves tissues of oxygen, producing more acid. It spirals downwards.
And what else is happening?
This persistent hypoxia and acidosis directly injure the endothelial cells lining the blood vessels. They get swollen, leaky. And this endothelial injury is the tripwire for widespread clotting. It massively increases the risk of disseminated intravascular coagulation, DIC. The system is starting to clot inappropriately everywhere. Hashtag 3, irreversible stage.
And if that vicious cycle isn't broken quickly, we descend into the final grim stage, the irreversible stage, where even heroic efforts often fail.
Sadly, yes. At this point, cellular injury is widespread, severe, and, well, irreparable. A key sign is the failure of cell membranes to maintain their normal ion gradients. Sodium rushes in, potassium rushes out, cells swell.
And inside the cell.
Crucially, lysosomes, the cell's recycling centers, rupture. They release their destructive hydrolytic enzymes into the cytoplasm, basically digesting the cell from within. This leads to necrosis, cell death.
The whole system is just collapsing.
It is profound systemic collapse. Worsening myocardial failure is a big contributor now. The heart muscle itself is hypoxic, acidic, and dysfunctional.
Not just from the original cause, but from the shock state itself.
Exactly. Plus, the ongoing release of inflammatory mediators and nitric oxide from the progressive stage keeps making things worse. More vasodilation, weaker heart contractions.
And the body's own defenses can backfire now.
Terribly so. For example, remember how blood flow to the gut was sacrificed early on?
Right.
Well, now the ischemic bowel wall can break down.
Yeah.
The barrier fails. This allows normal gut bacteria intestinal flora to leak across the damaged wall and into the bloodstream.
Oh, no.
So now you have bacteremic shock superimposed on whatever the original problem was, trauma, hemorrhage. It just exponentially worsens the patient's inflammatory state.
And the kidneys.
Total renal failure is highly likely. The prolonged lack of oxygen kills the kidney tubules, acute tubular necrosis. By the time a patient hits this irreversible stage, even if you manage to get their blood pressure back up with fluids and drugs, it's often too late to save the cells. Organ function doesn't recover, and death is, unfortunately, almost certain.
Okay, now let's tackle the most complex form, the one that's really a molecular war, septic shock. This is where it gets really interesting, because the system fails not due to a mechanical issue, but because of this massive self-destructive biochemical overreaction.
Yeah, this is a huge clinical challenge. We're talking, over 750,000 cases a year in the U.S. alone. And despite everything we can do, the mortality rate for severe sepsis and septic shock is still devastatingly high, maybe up to 50%.
Wow.
So understanding this pathology is really at the cutting edge of critical care. Hashtag the dysregulated host response.
Let's start right at the beginning of sepsis. The trigger is infection, obviously, but the problem isn't just the bug itself.
No, it's defined as a dysregulated host response to microbial products. The body's immune cells, macrophages, neutrophils, even endothelial cells lining the vessels recognize molecular danger signals.
What kind of signals?
Two main types. First, pathogen-associated molecular patterns, PAMPs. These are common structures found on microbes like lipopolysaccharide, or LPS, which is part of the cell wall of gram-negative bacteria.
Okay.
Second, damage-associated molecular patterns, DAMPs. These are distress signals released by our own injured or dying cells during the infection or tissue damage.
And how do our cells see these PAMPs and DAMPs?
They have specific receptors. The most famous are the toll-like receptors, TLRs, on the cell surface. TLR4, for instance, is key for recognizing bacterial LPS.
And when a TLR binds its target?
It flips a switch inside the cell. It activates key transcription factors, primarily one called NFB nuclear factor, kappa B.
And epi, is that the master alarm switch then?
You could call it that. Once NFUB gets activated, it moves into the cell nucleus and turns on the genes responsible for inflammation. This unleashes a massive systemic cytokine cascade.
Okay, cytokines. We hear that term a lot. Let's break it down. What are the key players here that cause the damage?
Well, the initial wave includes really powerful pro-inflammatory mediators. Tumor necrosis factor, TNF, and interleukin-1, IL-1 are probably the most critical early ones.
What do you do?
TNF is a potent driver of systemic inflammation, fever. But dangerously, it increases vascular permeability, makes vessels leaky, and can even trigger programmed cell death, apoptosis, in endothelial cells. IL-1 does similar things, driving fever and inflammation.
And there are others.
Oh, yes. High levels of interleukin-6, IL-6, which tells the liver to pump out acute phase reactants. Interferon gamma, IFN-nuc. And later in the process, you get mediators like HMGB1 high mobility group box 1 protein. Yeah, it normally lives inside the cell nucleus. But when cells die messily, it gets released and acts as a late-stage damp, keeping the inflammation going long after the initial trigger might be gone.
Wow.
And don't forget the complement cascade. Another ancient part of the immune system gets activated, producing things like C3a and C5a. These are anaphylatoxins. They trigger mast cells to release histamine, driving even more vasodilation and inflammation. It's a storm. Hashtag tag endothelial activation and leakage.
So we've got this intense systemic chemical soup flooding the body. How does that immediately cause the circulatory collapse, the low blood pressure of septic shock?
The primary target is the vessel wall itself, the endothelium. Those pro-inflammatory cytokines, especially TNF and IL-1, directly attack the tight junctions between endothelial cells.
The glue holding the vessel walls together.
Exactly. Think of it like the cytokines start dissolving that glue.
You mentioned opening the floodgates earlier. It sounds like the whole vascular system just becomes leaky.
That's exactly what happens. You get widespread vascular leakage. Protein-rich fluid pours out of the vessels into the surrounding tissue, the interstitium.
Okay.
This massive third spacing of fluid does two bad things. It depletes the effective circulating volume inside the vessels, and it creates physical distance between the capillaries and the cells, making it harder for oxygen and nutrients to get across.
Which is why they often need tons of IV fluids.
Yes, massive fluid resuscitation is often necessary, but it's tricky because the fluid can just leak out again if the vessels remain leaky.
And the vessels themselves are forced open too, driving the low pressure.
Right. The activated inflamed endothelium releases massive amounts of nitric oxide, NO.
Nitric oxide? Isn't that normally usable?
It is, in controlled amounts, for signaling. But here in these huge quantities, it's a potent systemic vasodilator. It relaxes blood vessels everywhere.
Okay.
Combine that with other mediators like platelet activating factor, PAF, and you get profound systemic hypotension. The body just loses its ability to maintain vascular tone.
And what about the tiny vessels, the microcirculation? You mentioned dysfunction there.
Yes, this is critical, and why sepsis is so lethal. Beyond the big drop in overall blood pressure, the smallest vessels, the capillaries, lose their normal ability to regulate blood flow based on local tissue needs.
How so?
Normally, if a tissue needs more oxygen, its local arterioles dilate. In sepsis, flow becomes completely chaotic and heterogeneous. Some capillary beds might be wide open with blood racing through too fast to drop off oxygen, while others nearby are completely clamped down or sludged with cells. Flow is intermittent and mismatched.
So even if the main blood pressure number looks better with drugs?
The cells might still be starving because the microcirculation isn't delivering the oxygen effectively. That clinical blood pressure reading can be deceptively reassuring. Oxygen delivery at the cellular level is still critically impaired. Hashtag the procoagulant state, DIC.
Okay, we have to talk about the terrifying complication. Disseminated intravascular coagulation, DIC. Sepsis makes people clot everywhere and bleed uncontrollably. How does that happen?
It's a devastating paradox. Affects maybe up to half of septic patients and really signifies total system failure. The pro-inflammatory environment basically flips the body's entire coagulation switch to on.
How?
Those cytokines strongly promote clotting. They cause monocytes and endothelial cells to dramatically increase their expression of tissue factor. Tissue factor is the main initiator of the clotting cascade.
So the accelerator is floored. What about the brakes? Are there natural anticoagulants?
There are, but they get shut down. The cytokines simultaneously downregulate the body's natural anticoagulant systems. They decrease thrombomodulin on endothelial cells, which prevents the activation of protein C, a really vital natural anticoagulant. And they also inhibit fibrinolysis, the process of breaking down clots, by increasing levels of PAI1, plasminogen activator inhibitor 1.
So building clots like crazy and stopping the cleanup crew.
Precisely. This leads to widespread, uncontrolled deposition of tiny fibrin-rich thromby microclots throughout the small vessels of the body: kidneys, liver, lungs, brain.
And those clots block blood flow.
They do. They cause microvascular occlusion, leading to tissue ischemia and organ damage.
Then where does the bleeding come from?
That's the cruel twist of consumption coagulopathy. This runaway clotting consumes platelets and essential clotting factors like fibrinogen, factor V, so rapidly and so extensively that the body literally runs out of them.
So there's nothing left to form a normal clot when needed.
Exactly. If the patient gets even a minor injury or just needs blood drawn, they can't form a stable clot because all the raw materials have been used up making microthrombi everywhere else. The result is simultaneous tissue damage from clotting and catastrophic bleeding oozing from IV sites, internal hemorrhage, hemorrhagic strokes. It's chaos.
And I read something about nets contributing too.
Yes, neutrophil extracellular traps, nets. These are sticky webs released by neutrophils trying to trap bacteria, but they also provide a scaffold that promotes thrombus formation, adding to the DIC problem. Hashtag metabolic derangements.
Just a breakdown on every level. Let's look at the metabolic chaos too, specifically glucose dysregulation. What happens with blood sugar in sepsis?
The metabolic state gets severely messed up. You see profound insulin resistance and hyperglycemia, high blood sugar.
Why? Is it just stress?
It's a combination. The systemic stress response, massive release of glucagon, cortisol, and catecholamines drives the liver into gluconeogenesis overdrive. It starts pumping out glucose like crazy.
The body thinks it needs energy to fight.
Right. But here's the problem. The tissues can't use that glucose effectively. The circulating cytokines actively interfere with insulin signaling.
How?
They impair the ability of muscle and fat cells to respond to insulin, partly by suppressing the glucose transporter GLUT4 from getting to the cell surface to let glucose in.
So you have tons of sugar floating around in the blood.
Extremely high blood glucose, hyperglycemia.
But the cells are functionally starving for fuel.
Exactly. It's a massive disconnect.
Why is that high blood sugar itself so dangerous in sepsis? Seems counterintuitive.
It's a critical piece of self-sabotage. That hyperglycemia actually suppresses crucial immune functions, particularly neutrophil function.
The bacteria-eating cells.
Yes. Neutrophils are the foot soldiers you need to clear the infection. High blood sugar impairs their ability to move, engulf, and kill bacteria. So the stress response, by raising blood sugar, actively hinders the fight against the underlying infection. A terrible, vicious cycle.
And the adrenal glands can take a hit too.
Yes, always have to consider adrenal insufficiency in septic shock. It can be a functional deficit. The glands are just exhausted from being constantly stimulated. Or it can be actual tissue death, necrosis of the adrenals. That's called Waterhouse-Friderichsen syndrome.
And losing adrenal function.
Means losing cortisol and aldosterone production, which makes the hypotension and systemic collapse even worse. Hashtag organ dysfunction morphology.
So you put it all together, the failure of perfusion, the widespread edema, the thrombosis, the cellular hypoxia. It culminates in multi-organ dysfunction and failure.
That's the end result, unfortunately. The damage is systemic. The kidneys are incredibly vulnerable. That prolonged hypotension and the microthrombi cause ischemic damage. Acute tubular necrosis often leading to complete renal failure needing dialysis.
And the liver, lungs.
In the liver, the hypoxia causes cell death, typically around the central veins, central lobular necrosis.
Right.
And the lungs. The lung failure in sepsis is often particularly severe and has a specific pathology.
Different from, say, hypovolemic shock.
Very different. In hypovolemic shock, The lungs are often spared initially. But in severe sepsis or major trauma conditions with massive inflammation, the lung frequently gets hit hard, leading to diffuse alveolar damage, DAD.
That's shock lung, ARDS.
Clinically, yes. Acute respiratory distress syndrome, ARDS. The alveolar membranes get damaged, leaky, filled with protein-rich fluid, non-cardiogenic pulmonary edema. Gas exchange just becomes impossible.
And even the heart muscle itself gets damaged by sepsis.
Absolutely. Septic cardiomyopathy is a well-recognized entity. The sustained cytokine assault, the acidosis, the metabolic chaos, all directly depress myocardial contractility. The heart fails not just because of loading conditions, but because the muscle cells themselves are poisoned and dysfunctional, further compounding the circulatory collapse. Hashtag updates, context, and treatment challenges.
Okay, if we connect all this deep pathology back to the clinic, the bigger picture, we should touch on the modern context. The source material mentioned the 2016 consensus definitions for sepsis.
Yes, sepsis 3. That was important for standardizing things. We moved away from just looking for signs of inflammation.
So how is sepsis defined now?
Sepsis is defined as life-threatening organ dysfunction caused by that dysregulated host response to infection. And septic shock is the subset with particularly profound circulatory, cellular, and metabolic problems needing vasopressors to keep blood pressure up, despite fluids and having elevated lactate. It signals a much higher risk of death.
And this link between infection and generalized inflammation leads to the idea of SIRS, systemic inflammatory response syndrome.
Right. SIRS highlights that you can get the same kind of massive systemic inflammation without an infection. From severe non-microbial insults, massive trauma, bad burns, acute pancreatitis.
It's the same inflammatory cascade.
Essentially, yes. It shares that massive outpouring of inflammatory mediators, causing vasodilation, leakiness, organ dysfunction. And this concept is really relevant today with things like cytokine release syndrome, CRS.
Through cancer therapies.
Exactly. Seen in patients getting advanced treatments like CAR T-cell therapy. The pathology, the overwhelming cytokine storm, is functionally identical to SIRS and sepsis, needing similar critical care support.
This brings us back to that immune paradox you mentioned. The body starts hyperinflamed, causing damage, but then it seems to flip into paralysis.
That dual nature is why treatment is so incredibly difficult. The initial hyperinflammatory storm quickly triggers powerful counter-regulatory immunosuppressive mechanisms. The body tries to slam on the brakes by shifting from pro-inflammatory Th1 responses towards anti-inflammatory Th2 responses. It releases mediators like interleukin-10, IL-10, which is a potent immune suppressor.
And the consequence of that swing.
It leads to widespread lymphocyte apoptosis, programmed cell death of key immune cells like T cells and B cells. So the patient might survive the initial inflammatory firestorm.
Only to become incredibly vulnerable later.
Exactly. They often die weeks later from secondary infections, maybe invasive fungal infections, or ventilator-associated pneumonia, because their immune system has become functionally paralyzed. They oscillate between these two lethal states, deadly inflammation and deadly immunosuppression.
Why can't the body manage that balance better? If the inflammation is so dangerous, why not shut it down earlier?
That's the multi-million-dollar question in sepsis research. It seems to be a problem of, well, overwhelming positive feedback loops and timing. The initial inflammatory blast is necessary to try and contain the infection locally.
Right.
But once that cascade gets going systemically, NFEB, TNF, complex, it's like a runaway train. By the time the counter-regulatory breaks like IL-10 really ramp up, either the initial damage is already too widespread or the subsequent immunosuppression is too profound, leaving the patient defenseless.
Which explains why trying to block specific inflammatory molecules hasn't really worked out in trials.
Precisely. The complexity explains why attempts to intervene with specific cytokine antagonists, blocking TNF or blocking IL-1, have largely failed, or sometimes even made things worse.
Timing again.
Timing, redundancy. Block one pathway, others compensate. Block inflammation too early, maybe you hinder clearing the infection. Block it too late, maybe you worsen the immunosuppression. It's incredibly complex.
So the standard of care remains supportive?
Fundamentally, yes. Rapid broad-spectrum antibiotics to fight the source infection. Aggressive 5E fluids in vasopressors like norepinephrine to support blood pressure and perfusion. Supplemental oxygen to combat hypoxia. We're mainly treating the consequences while trying to eliminate the trigger.
And one last specific trigger mechanism we should mention, superantigens. They cause shock too, but differently.
Yes. Superantigens are toxins secreted by certain bacteria, like the Staphylococcus strains causing toxic shock syndrome.
How do they work?
They bypass the normal specific immune activation process. Instead of needing a precise fit, They act like a master key, directly linking immune cells, T cells and antigen-presenting cells, together non-specifically.
Resulting in
Massive polyclonal T lymphocyte activation. Huge numbers of T cells get turned on all at once, releasing an enormous flood of cytokines. This causes a rapid onset shock syndrome, vasodilation, leakiness, organ failure that clinically looks a lot like septic shock, but the initial immune trigger is different. #tag conclusion.
So what does this all mean for us, for the learner? We've gone from the initial failure pump, volume, or pipes through the body's frantic compensation down into the molecular chaos of NFP and cytokine storms and sepsis.
I think the synthesis is clear. Shock, at its core, is a failure of oxygen and nutrient delivery right down to the cellular level. And the first step is always to categorize the cause.
Right.
Is it mechanical, pump failure and cardiogenic, or missing volume and hypovolemic?
Right.
Or is it this overwhelming biochemical inflammatory disruption we see in sepsis?
And clinically, that simple observation of the patient's skin cool and clammy versus warm and flushed can be such a critical first clue, can't it?
It really can. It helps guide those initial decisions. Does this patient need more fluid? Do they need support for their heart pump? Do we suspect infection and inflammation are driving vasodilation? Speed and precision in diagnosis and treatment are absolutely everything.
And we have to keep in mind the prognosis difference.
We do. While a young, healthy person with straightforward hypovolemic shock from blood loss might do very well if treated quickly, the outcomes for patients with advanced septic shock or severe cardiogenic shock remain incredibly challenging, even with modern ICU care. It just underscores the need for rapid, expert intervention based on understanding this deep pathology.
You know, our journey through this really highlights this intense biological conflict, especially in sepsis. The body tries to defend itself against microbes, but the very weapons it uses, that cytokine storm, become the instrument of its own systemic collapse.
It leads to a really provocative question, doesn't it? Something for you, the listener, to maybe mull over.
Which is?
If the immune system, our fundamental defense, is ultimately the cause of death in severe sepsis, how fine, biologically, is that line between defense and self-destruction? The body's innate response is absolutely essential to fight infection, yet that same response, unleashed systemically, can be catastrophically fatal. It's a profound and often tragic paradox at the very heart of critical illness.